this week's Cardiology Countdown will begin at the number 3 spot with the newly released ACC, AHA, SCI, STS, and several other group appropriateness criteria for revascularization. Now, this looks at the various indications and has an evidence-based review of when revascularization would be appropriate, which type of revascularization would be evidence-based and the best one for patients, and grades them according to the level of evidence and what the committee feels would be appropriate or inappropriate use. And this is something that is coming to all of our clinical care, of incorporating that to make sure that appropriate use of procedures, avoiding underutilization in patients who are at high risk and need revascularization, and avoiding overuse in patients where it would not be indicated. There's several updates incorporating the Syntax trial, of course the Courage trial, and risk stratification built into indications for revascularization in acute coronary syndromes. Now, at the number 2 spot is an interesting paper in the European Heart Journal that's a randomized trial looking at different ways to avoid contrast-induced nephropathy in patients undergoing percutaneous procedures. It studied a standard approach of hydration beginning before the PCI and continuing 12 hours after with sodium chloride, the standard approach, and then 2 regimens of sodium bicarbonate that had been suggested in some smaller studies to perhaps do a better job. This was done for a shorter period of time, and then one very brief infusion was the 3rd regimen of sodium bicarb. They found actually that the standard hydration with sodium chloride was the best and avoided changes and worsening of renal function. And so it reaffirms the fact that this is a key thing to look at and make sure that patients are well hydrated for procedures. And at this week's number 1 spot is a paper in Circulation that looks at the strategy of continuing warfarin at a therapeutic level during Afib ablation. And that as opposed to a strategy of interrupting warfarin, bridging with heparin, and then getting back onto warfarin. They found in an evidence-based review of thousands of patients, I believe 18 studies, that they had a markedly lower risk of thromboembolic complications with the continuous warfarin strategy. It was 90% lower risk of complications. They also found a lower risk of bleeding when continuing warfarin, and no increase in major bleeding. It was numerically lower rate of bleeding and not statistically different between those 2 strategies. And so this paper, I think, really helps reaffirm that maybe the optimal strategy for Afib ablation is to continue warfarin. So for this week's Cardiology Countdown, I'm Chris Cannon.